please start.
Good afternoon. I'm Dr. Shivani, one of the candidates for the exam today. I have gone through my case and I'm now ready for the discussion.
Okay, so now you have a case of Miss Amina Noor, and as you can see, she is coming with sudden onset severe pain. Okay,
Mm-hmm. Mm-hmm.
what information would you like to collect with this patient?
So firstly, I see that she has come in with her mother and she's come in the emergency. So I would, and she's 17 years old, and she has sudden lower abdominal pain and vomiting. So firstly, I would like to rule out any allergies. And after confirming her name and age, I will rule out any allergies and I'll give her medication for pain and vomiting. And after that, I will ensure her that everything she's going to tell me is going to be confidential. I'll ensure confidentiality, and then I will ask her the nature of the pain, the onset of the pain, the site of the pain, if the pain is radiating elsewhere. And I'll ask her how much is the pain on the scale of 0 to 10. And if the pain is radiating to the umbilicus, and if there's any event that preceded the pain, and I'd like to know if there's something that is increasing the pain or the aggravating factors or the relieving factors. And then I'd like to know about the vomiting as well, since when is she having the vomiting and what are the contents in the vomitus, if it is associated with epigastric pain also. And then I would like to also know if she's having any urinary complaints, any bowel complaints, any constipation or diarrhea. And I would also confirm her last menstrual period. And I would like to, in confidentiality, I would like to ask her if she ever has any discharge down below, or any, and if she's sexually active, or any history of any sexually shared infection if present. And I'd also like to do a urine pregnancy test for her. And I'll take all this history, and then I would also like to, if she says she's sexually active, I'd like to know about the contraception. And then apart from that, I'd like to know her medical history and any surgical history. And I would also like to know if she had any prior complaints similar. And then I would like to know about any significant family history. And I would like to know if she's having, I'd like to know her social history, if she smokes, consumes alcohol. And then after that, I would like to know her weight to height ratio, her blood group, and if she has any restriction to blood transfusions. So I'll take this history from her.
Okay, so I just asked about the information, not the history. Okay, so you have said correctly about the history that you'd like to take, however, it was a little bit extended. The observation of the case is show that her blood pressure is 98/60, and the heart
Mhm,
rate is 115 per minute, and the temperature is 37. By
mhm,
examination, you found that there is marked right iliac fossa pain and gardening and adnexial tenderness.
mhm,
The investigation that you requested, urine pregnancy test is negative,
mhm,
and her blood show for the hemoglobin normal, and the white blood cells is 14.
mhm.
Okay, so anything else would you like to know?
Um, I would, since she's having vomiting, I would like to know her electrolytes, and I'll also like to send her for an emergency transvaginal scan.
Okay.
And
Okay. So the scan results show that there is HCM complex sets, and this is,
mhm,
the picture is in front of you, and
mhm,
it shows calcifications, most likely of a dermoid cyst. There is
mhm,
also enlarged edematous ovary and peripheral follicles. There is
mhm,
reduced blood flow in the Doppler.
mhm. Okay, so ma'am, with all these findings, as she's having her BP is also low, and also she's having tachycardia, so she's dehydrated. So I'd like to give her, resuscitate her with fluids first, And with all the history that is given, so it is most likely that she's having ovarian torsion due
That they-
following due to dermoid cyst.
So what is your differential diagnosis for this case?
So the differential diagnosis could be it could be any pelvic mass, or it could be a fibroid which has undergone torsion, or it could be appendicitis could be a cause. It could be a urinary tract infection as well.
Mhm.
So these will be my diagnosis, or it could be an endometriotic cyst could be present that can also cause pain. So, or I would also like to know if she's had any history of PCOS. A large cyst can also undergo torsion if she's having PCOS.
Okay. So I think that the Romoid is enough, right? Okay.
Yeah.
So now, my second question for you, this is about the investigation that would you like to add? If there is anything that you like to add for this case?
I would like to know her blood group, and apart from that, her electrolyte levels, urine test, and the CBC has been a complete blood count has been done for her, and
Okay.
yeah.
So what's your management at the moment?
So at the moment, since she's come in the emergency, firstly I'll stabilize her. I'll give her fluids. I'll give her painkillers and antiemetics, and after that I'll admit her and I'll inform my consultant, a consultant on floor, and then I will tell her, explain to her and her mother about the situation, and I can also then we will plan her for emergency laparoscopic surgery for detorsion of the ovarian cyst. And
Okay. So you are going to plan for laparoscopy, right?
Mhm.
Okay. So what do you prefer? Laparoscopy or laparotomy in this case?
I would go for laparoscopy since she's a young girl, and I would also like to know the size of the cyst.
It's 8 cm.
Uh, so I can go for we can go for laparoscopy approach.
Okay. Okay. So my question for you, after you have stabilized the case, right, and you discuss the diagnosis with the family, okay, and she is at the moment, okay, she's being stabilized. Now
Mm-hmm.
we can move to theater, okay.
Mm-hmm.
So please tell me what is your intraoperative plan?
We will do detorsion of the cyst, and then we will leave it like that, and then we can plan. We can repeat the ultrasound at 6 to 12 weeks, and then we can go for the cystectomy later.
Mm-hmm. Okay, so why not considering oophorectomy?
Affecting because she's a young girl, so it will affect her ovarian reserve. So instead of doing oophorectomy, we will do the detorsion, and we can do oophoropexy, and we can later do remove the dermoid cyst at a later surgery, because at present there will be a lot of edema, so there are more chances to damage to the ovary. So
What even if the ovary looks black or blue?
uh, if it is a dusky looking ovary, then we can go ahead with detorsion only, because mostly the supply will get restored because of the double supply, dual supply is there. So it is not advisable to do oophorectomy for her.
Okay, okay. So, would you please take me quickly, okay, to the steps of the operation?
Mm, could you repeat the question?
Could you please take me quickly to the steps of the operation? The patient already you have now, okay, the laparoscopy equipment, everything, camera in place, okay. So you said that you're going to examine the ovary and you're going to make the torsion, okay. So how about the cyst? Are you going to remove the cyst in the same?
No, firstly, I'll do untwisting of the ovary, which is the detorsion, and that will restore the blood flow. And then after that, we can fix the ovary in place by oophoropexy. That will help prevent the recurrence. And after that, later we can plan the cystectomy.
Okay, okay. So during the cystectomy operation, what is the important thing that you would like to take care of?
That the cyst is removed in a bag, and so that there is no spillage into the abdomen, and that can cause chemical peritonitis.
Okay, that's good. Okay, so what is your post-operative plan?
Post-operatively, we will monitor her vitals and do a strict input-output charting for her, and we will do the early mobilization, and we will do debriefing, and we'll remove the catheters early and not keep them in place for long, and we will do the debriefing of the relatives and arrange a follow-up for her in the gynecology clinic.
Okay, okay. So if there is anything between you and discussion of the patient regarding the fertility reassurance, regarding the follow-up for the histopathology report?
Yeah, so I'll also advise her that the fertility is not usually affected because it is not affected too much when we as we are not removing the ovary. So I'll give her advice about that, and also I'll let her she'll get a call regarding her histopathology report from the hospital of the cyst.
Okay, okay. Thank you very much.
Thank you, ma'am.
Okay, thank you very much. You did really well. Apart from at the beginning, I thought that you will not be able to finish on time, but you did well. Thank you very much.
Thank you, ma'am.
Thank you, my dear. Okay, so let's have a look, my dear friends, to this case. Um, Dr. Shivani, she helped us, okay, in the presentation. And for the cases, the examiner approach for this case usually will be asking you about the information that you would like to take. Information would include, for example, the history of the patient, but we will focus on the history, in this case, on the history of the present illness mainly. Okay. And this is because we will consider this is an emergency, right? So we are not going to ask the patient about every and each detail in her life, but we would like to know information about the pain, right? The sudden onset, severe right-sided, constant or colicky, right? And if any other associated symptoms. We'd like to know also about her gynecological history, right? That's very important, especially for uh, the last menstrual period. We want like to know quickly her past medical history, if there is any chronic illness, right? And would like to examine her. For the examination, we are looking for the general examination and we are looking for the abdominal examination. For the ultrasound, we would like to arrange pregnancy test since we are preparing the case for likely surgery. White BCs, this is need to be done, and hemoglobin at least. This would be the initial thing that I would like to know, right? And regarding the management, so always we'll have the emergency, so admission, analgesia, IV fluid, consent taking, and informed sitter and senior involvement, of course. The case is arranged first, my dear friends. We are going to advise laparoscopy, right? Because I've seen Dr. Iram, you are considering that laparotomy. So for 8 cm, this could be done this way or this way. So this one of the things that we need to counsel the patient about in the consent taking is about the possibility to turn into a laparotomy, right? This is important. Another thing that regarding the intraoperative, okay, for the intraoperative, my dear, always when you're starting intraoperative or the examiner asks you about the steps of the surgery or something like this, always there will be an inspection and the examination of the organ, okay, of the internal organ. This is as a start with, right? And examining the intraoperative findings. So you have seen things by scan, right? You have seen the torsion by scan and the cyst by scan. So very important is that you look by your eyes as well, okay? So this is the best, of course, informative part of your the investigation, because you will see your eyes what is the situation and what is the extent of the damage in the ovary if there is any. Okay. So Dr. Mariam, my dear, it's laparoscopy can be done, okay, for 8 cm, right? However, still this will depend on the expertise of the surgeon, right? And according to also the case itself, the details in
Ma'am,
the case.
sorry to
But
interrupt. Will it be depending upon the vitals of the patient? If she is unstable, then laparotomy. If she is stable, then laparoscopy.
yeah, but this patient now she's not bleeding inside, right? This
But
is
vitals, ma'am, you told 190, I think 98 was BP and 110 was pulse.
it wasn't that much, because she's not bleeding inside. The problem with the patient was mainly the pain.
Okay.
Okay, so patient was distressed because of the pain. Okay, so now if you want to manage this patient, she's not bleeding inside, she's not like a ruptured ectopic, right? So we can go for the laparoscopy in this case. Regarding the size, the dermoid, okay, can be delivered. We call it like this, okay? The cyst can be delivered via mini laparotomy if you're not able, okay, to have all the cyst in the retrieval bag and take it from the umbilical port. So this is now, the surgery regarding the dermoid cyst. However, the college advised us to avoid the spillage of the cyst content, right? And that's mean be careful of the spillage because this will lead to a peritonitis. So what is the advice? Again, try to deliver the cyst. Okay, so sometimes can be if the cyst content is more of fluid, it can be suction of the fluid content,
The
right?
slides aren't moving if they're meant to be moving. Sorry.
I'm not speaking. Oh, I'm just speaking.
Yeah, we can't see anything. I mean, if thanks.
Okay, I will show you one surgery for the torsion. Okay, at the moment I'm not speaking from a slide. I'm just speaking.
Okay.
Right. I'm just explaining to your friend. Okay, so if we do have a big dermoid like this, okay, and I want to do cystectomy for this big dermoid, of course I will avoid at all, right, spillage of the cyst content because of that peritonitis. So the college advised that we will have the retrieval bag, right, and there are so many kind now of the types now of the retrieval bags, okay, to make sure that everything is inside. I can make like a suction of the content, okay, and after making this suction of the content, I can deliver, okay, the cyst through a mini laparotomy. You know the Hasson technique, something like that. I can make a mini laparotomy near to the port, the umbilical port, and take the retrieval bag from this side. Otherwise, if this is not possible or you are dealing with more of a solid content, okay, so you can have it like a laparotomy by a transverse incision. Okay, my friend?
Also, sorry to interrupt, but the plan would be doing a detorsion if it's blue and black, because that just shows that it's edematous and revascularization will happen. But we can't leave a dermoid with oophoropexy. I mean, dermoid needs to be removed then and there. However, if it's a functional cyst, oophoropexy could be, an interval cystectomy could be one of the options. But with the dermoid cyst, we need to do it not interval, but then and there as per the talk.
Yes, of course. I'm just answering your friend
Okay.
question. Chat box asking, okay, 8 a.m. Shall I go for laparoscopy? How can I go for laparoscopy? This was the question.
Okay.
Okay, thank you very much, Dr. Kanji, for this notes. Okay, so let's go for the part of the ovarian torsion here. Okay, and I will let Dr. Akansha, my dear. Okay, Dr. Akansha, tell us about
Yes.
this, please.
Tell us about what, ma'am? Sorry.
The TOG.
The TOG, yeah.
Yes,
Okay, so
the
the new TOG tells about the ovarian torsion, and it has divided according to the age of presentation, like the premenopausal and postmenopausal. There are some risk factors of ovarian torsion. That's starting with a history of PCOS or any kind of ovarian cysts. So in that 5 centimeters to 10 centimeters are likely to undergo torsion. More than 10 centimeters doesn't undergo torsion because of the size itself. So it won't be very mobile. Dermoid is likely in 21% to undergo ovarian torsion. However, in endometrioma, because of its nature of fibrosis, it's less likely to undergo torsion. So ovarian cyst and polycystic ovarian syndrome are one of the risk factors. Another risk factors being pregnancy, because in pregnancy progesterone hormones are released, which causes relaxation of the IP ligament and makes it more prone to torsion in pregnancy. And most likely it happens in the first and second trimester, where there's a lot of space. Apart from that, any previous ART treatment, like putting the patient at risk of ovarian hyperstimulation syndrome, that could put the patient at risk of ovarian torsion. And apart from that, another risk factor would be malignancies, but that is only complicating 1 to 2% of ovarian torsion. Again, because of its invasive nature, there won't be that much of buoyancy and mobility in a malignant ovarian cyst to undergo torsion, but it can form one of the risk factors. And lastly, the risk factor would be a previous history of ovarian torsion, which would cause another episode of torsion 5 to 18%. And however, if the torsion has occurred in a normal ovary, the recurrence risk is around 60%. So these are the risk factors for ovarian torsion. And then the talk talks about the management plan, where it says that if it's postmenopausal, which is very unlikely to present with torsion, in that case, we do plan for an oophorectomy because she's already attained menopause. So it's better to have a removal surgery, and it will have a shorter operating time. It will be easier. However, if it's premenopausal and where fertility is a concern, we need to go for some cystectomy. And in the background of polycystic ovarian syndrome, it's always better to go for a oophoropexy because it'll have 3 advantages. It will reduce the future recurrence risk and protect the hormonal function and reproductive function. And PCOS is something which will remain lifelong, so there are chances of recurrence. So oophoropexy would be a good option for a lady having a background PCOS. Apart from that, it talks about the various types and types of management, where it also talks about the percutaneous or transvaginal cyst aspiration, but it's most likely for cysts which are functional, like simple cysts. For them, aspiration is a better option, but otherwise, surgical management is the best treatment in an acute setting. And again, it talks about detorsion first, followed by either internal cystectomy or cystectomy in the same sitting, depending on the type of cyst. As I said, dermoid cyst cannot be left for an interval, but if it's any other type of cyst, depending on the consultant and the operating surgeon, the decision of interval cystectomy can be decided upon. And apart from that, oophoropexy is an option for PCOS, as I already said. And then it talks about the surgical details of cystectomy and detorsion. That is the talk basically about.
Okay, thank you very much, Maria. So we expect the case of the ovarian torsion in the exam because the ovarian torsion, you know, it's one of the commonest actually cases, and the examiner love it. Sometimes it comes as a role player, and in the role player stations like this, they give, for example, um a case that have already had oophorectomy, right? And she's asking, why did you do the oophorectomy to me after the surgery? Or they told me that it will be a simple surgery. Nobody told me that they are going to take away my ovary. Okay, and in this case, of course, we have to explain. So this is the cases as simple as that. This is very simple cases. And I would advise you, all of you guys, that we go for the TOG article, right? So here, for example, the TOG article start with the epidemiology, right, of that torsion, right, and the typical peak presentation for which age, and this is for the 29 to 34 years. And this is the pathophysiology and the risk factors. And of course, the most common cyst associated with ovarian torsion is the dermoid cyst. That's why we find in the exam, usually there is link between ovarian torsion and a cases present with a cystic teratoma or a teratoma. This is around 1/5 of the cases, or 21% actually, of all the ovarian torsion cases. The recurrent torsion happen in the PCOS, okay? And also this can happen with pregnancy. The ovarian torsion can happen during the pregnancy. There is patient who have ART, they suffer from 11-fold risk of the ovarian torsion. And of course, we have moderate to severe OHSS as a risk factor which can develop the ovarian torsion. Be careful of this because you will have a case of the OHSS, and one of the differential diagnoses of this case can be ovarian torsion, of course. There is a risk of recurrence, so this is something that we will include in the post-operative discussion with the patient about the risk of the recurrence. And the risk of recurrence, this is quoted to be 5 to 12%, okay? And this is if the incident occurred in a normal ovary, the risk of torsion will be high. Okay, so this is for the history of pelvic surgery. Why post-tubal sterilization? Okay, we find that post-tubal sterilization carry a risk of torsion very high. Okay, so previous pelvic surgery is a risk factor, will increase the risk of ovarian torsion, and tubal sterilization is particularly emphasized in this TOG article. Okay, so we found also history of tubal ligation as a sterilization method found in 21% of the ovarian torsion cases. The cases can present with sudden onset lower abdominal pain or pelvic pain, okay, that is unilateral, fluctuating, and severe. In cases of intermittent torsion, symptoms may fluctuate. Nausea and particularly vomiting is seen in 41% of the cases. Initial clinical signs like tachycardia are like 11%, and less commonly low-grade fever. Further examination may elicit a palpable abdominal or adnexial mass and suprapubic tenderness, guarding, and cervical excitation due to the peritoneal irritation. Onset of the ovarian torsion symptoms to initial presentation is most likely to be less than 8 hours. The ultrasound features is very important, so be careful because there is absence of sonographic evidence, okay, should not be taken as a reason to exclude diagnosis of the ovarian torsion. So it's important, but even if you don't find it, this does not mean you exclude this diagnosis. Okay, so the commonly described sonographic finding include asymmetrical enlarged ovary, okay? And ovarian stroma edema, the whirlpool sign, and the follicular ring sign, asymmetry of the Doppler flow, and this is late sign, and it has been found in normal in over half of the torsion cases, especially at early presentation, free fluid in the Douglas pouch, and the affected ovary may be displaced from their normal position on the ultrasound. Okay, so they can be found anterior or posterior to the uterus or contralateral adnexia even. Okay, so for the serum markers, if there is anything that could be done, that's why the examiner asking for investigations. Okay, so we are looking here for inflammatory markers, such as the white cell count and the C-reactive protein. Okay, of course, this is not an infection, right? But it could be there. Neutrophil and the lymphocyte ratio has shown to be higher, and the mean platelet volume lower in ovarian torsion cases. So we don't have a cutoff value, okay, for the diagnosis. This is a transvaginal ultrasound image of the sign of the whirlpool sign. And this is a color Doppler. It's applied lateral to the uterus over the supplying vessels to show the whirlpool formed by twisted vein and the artery. Transvaginal ultrasound in here, in this picture, okay, you find that follicle ring sign, okay? So the follicular ring sign, which means that this has happened like this, can see these follicles, okay? So this is in twisted ovary, and this is surrounded by a bright white ring. This is picture, okay, here, that perfectly show this. Oh, in real, you know, examples, you will find the edema and the signs and the Doppler as well. When to do MRI? This can be useful in non-specific presentation and at the presence of risk factor in the pregnancy. Okay, so this is the use of the MRI in the diagnosis. For the ovarian torsion and fertility, which is they are asking about it, okay, laparoscopic detorsion in premenopausal cases preserve ovarian function to support the future pregnancy. During the consent process, they should discussion regarding the future fertility outcome in premenopausal patient. Okay, so fertility will likely to be preserved if the ovary is detorted and no partial or complete ovarectomy is performed. Okay. So here, the torsion, confirm it. If it is a postmenopausal, then go for the unilateral salpingo-oophorectomy. Okay, so this will depend on the patient, age, postmenopausal, go for unilateral salpingo-oophorectomy. And if it is a premenopausal, right, so you will have two things. First of all, detorsion of the case, just detorsion. Okay, and according to the finding, if there is necrosis and no signs of revascularization, okay, so there are two options also for the conservative management or the unilateral salpingo-oophorectomy. For viable ovary, okay, so there is also options of the conservative or cystectomy or oophorectomy. Okay, so let's see. This is regarding the drainage, okay? And here they give you that aspiration is the fastest and lowest risk management option, okay? And the elasticity in the pedicle will naturally detort with rapid resolution of the symptoms. This is often within minutes. If symptoms don't improve, and then recourse to laparoscopy is still recommended. Appropriate only for anechoic simple cyst with cyst volume larger than the volume of the edematous ovary to allow significant size reduction of the ovary. Particularly useful approach in those at risk with significant comorbidities or risk with anesthesia. There are delays to definitive surgical management for cyst likely to self-resolve. Can be performed percutaneously or transvaginally, similar to a collection in the IVF, under local anesthetic only. Okay, and the procedure should always be under ultrasound guidance. So this is for the percutaneous or transvaginal drainage. Counseling regarding the surgical approach. Okay, and this can come as a straightforward counseling station in your exam or can come as a part of discussion. The previous practice was concerned about the risk associated with the conservative management after detorsion, particularly thromboembolism and post-operative infection. So neither complication is confirmed to be higher than if the detorsion is performed. Conservation of the ovary is considered safe, and key parts of the history to consider are the following. Number one is menopausal status. So in menopausal status, what shall I do? Post-menopause, what shall I do?
Hysterectomy.
Yes, exactly. So in a postmenopausal woman, what I will do is simply oophorectomy, right? And it's a reasonable option, right? Short operating time than a cystectomy, and it provide a definitive solution against recurrence. That's simple. And the other one is the previous history of oophorectomy or single ovary, particularly in a younger patient. So in that scenario, I will go for the torsion, of course. Torsion on the remaining ovary and a prophylactic oophoropexy to reduce the risk of the ovary, then protected the hormonal and reproductive function. So if you do have a woman with history of oophorectomy or a woman with a single ovary for whatever reason, right, you should perform the detorsion and the oophoropexy. Okay, so this is to keep her hormonal and reproductive function. Don't forget the risk of recurrence. For history of previous ovarian torsion, then in this case, you will perform oophoropexy, right, to reduce the risk of future recurrence. So one case, right, of ovarian torsion, I don't need to do oophoropexy, right? First case, a woman with 2 ovaries. First time she had torsion. Will you do oophoropexy, yes or no?
Recurrence is there, so I'll do oophorectomy to prevent future recurrence.
If this is one first time, okay? First time, okay? Compared to recurrence or single ovary. Single ovary or recurrence, I will advise the oophoropexy to keep the function, okay?
Yeah.
This is surgical evaluation and detorsion. Okay, here the direction in which the adnexia has torted should be ascertained, and it is important to remember grossly enlarged ovary, which is dark with or without hemorrhagic lesion, is most likely still viable. Okay, the dusky appearance is due to vascular and lymphatic congestion. In contrast, necrotic ovary appears poorly defined, and it will be gelatinous and highly friable. It is often sticky with adhesions, and detorting a necrotic ovary is likely to result in disintegration of the tissue. Necrosis is rare and normally occur after many days since the symptom onset rather than hours. Unless there is a true necrosis, there is likely degree of ovarian function retained, and so conservative management is favored. Okay, friends? So you can see this dusky appearance of the ovary. Okay, do you think that this is a dead ovary? Yes or no?
I'm sorry.
Do you think that this is a dead ovary?
No.
No. Okay, so this is due to the edema and congestion, right? So that's why they advise just to keep, everything and go for the conservative measure in this case. If it is necrotic, okay, so it will be friable and the dead tissue almost, it will be, also having some adhesions, and this is will be days after the onset of pain. Now, ovarian cystectomy. Now or later, shall I do ovarian cystectomy at the same time of detorsion? Yes or no? Shall I go with the patient to 2 operations? Yes or no? This is a question that everybody asking, right? So here at the moment, there is no actually evidence or consensus in the literature to support detorsion and cystectomy during same procedure. Okay, so we don't have evidence for this to do the cystectomy and detorsion in the same procedure. Overclosing and planning subsequent elective cystectomy in a later date. The decision whether to proceed with immediate or interval cystectomy should be individualized in each case and the discretion of the surgeon. The consequences of a second anesthetic should be considered, of course, as should the availability of semi-elective theater scheduling and risk of delay. If a second procedure is deemed the best option, this should be scheduled once, okay, this edema has subsided. Approximately, this should be 2 to 4 weeks following the original ovarian torsion. So, at the moment, I can do cystectomy in individual cases. There is no clear recommendation, right, actually for detorsion and cystectomy in the same time. However, look to your resources, look to the availability, right, of a second surgery and case as well, patient preferences and everything, okay, and then take your decision. When to do a oophorectomy, okay, the oophorectomy should no longer be performed unless there is necrosis and ovarian degradation, as ovarian function has been shown to be preserved. This procedure should be considered if there is a high suspicion of malignancy. The rate of malignancy in ovarian torsion is less than 2%, but ovarian torsion in postmenopausal patients should be accompanied by high index of suspicion for malignancy, and the rate of which this is reported to be 9 to 22. This is in the postmenopausal. It would be appropriate to offer conservative detorsion to alleviate the symptoms prior to onward referral to gynae-oncology for further assessment and definitive surgical treatment. Pelvic washing may be taken at the time of the detorsion and sent for cytology as well. The CA-125 is unlikely to be of benefit in those circumstances and should not be routinely performed. This could be an examiner twisted scenario. Okay?
So here we are saying that we'll do detorsion and oophorectomy, but at the same time it's saying that it would be we would offer conservative detorsion to alleviate, and then we refer her to the onco team. That means we just detort and leave it.
Okay, it could be according to the case.
Okay.
Right? So we always take these cases based on opinion, right? And it should be individualized approach rather than recommendation for everyone. Okay? But is here again, okay, could be considered. The oophorectomy could be considered if you have suspicion of malignancy, right? But you remember, this is very important. Whenever we have ovarian cancer, what is the appropriate surgical management?
We go for a staging laparotomy.
Yes,
And
and I try to do this without a proper consent, right? And a proper preparation for the patient and involvement
yes,
of.
by the onco team.
Yes, so if I have a higher risk, right, of malignancy, I wouldn't remove the ovary. Okay, I would send it better. I will do the conservative detorsion, right,
Okay.
to alleviate the symptoms, right, prior to onward the referral to the gynae oncology for further assessment and definitive surgical treatment. Okay, so this is what he is saying here. Okay, and also if you think about it, this will come in line with the most of the recommendation, right? Because if I do have risk of malignancy, okay, and I wanted to make an operation, it's better that it should be done in its place, right, with the MDT.
Okay.
For the ophropexy, where there is a wide variety superiority of one technique over another, the current rate following ophropexy have been estimated to be 9 to 16%. Anatomical structure reported in the literature are as anchor sites include. There is very little evidence to support sites of ophropexy. Okay, so can be respective pelvic side wall, the posterior abdominal wall, the uterosacral ligament or round ligament or posterior aspect of the uterus. Okay, an alternative to fixation of the ovary is plication of the utero-ovarian ligament. So suture material may be non-absorbable, such as fine proline, delayed absorption PDS, with the evidence of a paired suture to reduce unnecessary tissue trauma. Okay, the tissue need to be, or the suture need to be loose enough. Okay, and this is to not to pull through and tight enough that the bowel cannot herniate through the cause and cause obstruction. Okay, so the ophropexy, my friends, again, remember what's its indication?
So if there's a
recurrence and single ovary.
previously
Yes,
and
exactly.
recurrent.
Yes, that's great. So in the recurrent and the single ovary, thank you very much, Dr. Maisa. Thank you very much, Dr. Akansha. Okay, and this is, my dear friends, okay, laparoscopic is still, as you can see here, image demonstrating superficial part of the pelvic side wall and ovarian tissue with a clear operative field to reduce risk of the injury. Okay, so remember again that the suture material that will be used in this operation should be non-absorbable, right? Do you remember this?
Delayed period, not barbed.
Yes. Okay. So for the cases of the ovarian cystectomy and for the cases of the ovarian torsion, okay, the decision usually will be according to the cases individualized management. But for the examination point of view, and you have an oral exam, it will be very great chance for you to explain the knowledge, right? And the latest recommendation of the TOG article. You can even show the examiner that you are aware when to consider the ophropexy and not when not, when to consider the cystectomy and when not. Okay, so as a rule of thumb, most of the cases with ovarian torsion doesn't need anything more than
Detorsion.
yes, detorsion. Okay, and the cases that need the ophropexy, those are the cases with recurrence or the cases with ovarian torsion, right? Sorry, recurrence or single ovary. So this is the cases. Yes, when to consider the cyst removal along with the detorsion. This will depend on the individual scenarios. Okay. Why? Because my friends, sometimes it's availability of the ovarian, of the elective procedures, risk of the second anesthesia, patient wishes as well, patient circumstances. Okay, so this is all to be considered in the same time. If you do have a case of HCM, dermoid, and torsion in the same time, what do you think? Shall I do the cystectomy in the same time while I'm doing the detorsion?
Yes, I feel.
Okay, so I have one doctor says yes, and how about the others?
What was the question? Just repeat that for me.
If you have a torsion, okay, with a dermoid cyst HCM, right? Are you going to consider the cystectomy in the same time? Yes or no?
No.
Okay, so in the exam, okay, even the TOG article or other guidelines, okay, other than the RCOG guidelines, they didn't give us a clear cut
Yeah.
of what to do, but they leave it to the expertise of the surgeon, right?
Operating
And
surgeon would decide.
yes, operating surgeon will decide according to the circumstances and individualized management. Okay.
So we give the pros and cons of each. That would be the safest answer.
Yeah. Yes.
Okay.
This is absolutely. And look, my dear friends, the conservative surgery now is the standard, right? This is now the standard. So what you will do, laparoscopic detorsion and ovarian conservation. This is what now all the, the guidelines and all the recommendation agree for this. Okay? This is the current practice, and the most guidelines recommended laparoscopic detortion as the preferred treatment to preserve ovarian function and future fertility, especially in children, adolescents, and reproductive age women. Okay? And the ovarectomy is no longer a routine simply because the ovary become ischemic, or you show that this is blue, or you see that it's gangrenous, doesn't mean that it's dead. Okay, this is most likely it's because that congestion. Okay, so nowadays most of the evidence towards the detorsion and conservation. However, there is still a place, as we have explained in this TOG article, for individualized management, putting in mind individual circumstances, okay, and the local availability, and also for the Pixie for the cases of recurrence or the cases of single ovary. Okay, so this will be for a perfect answer in the exam.